Hello and good day. So today we're going to talk about your nervous system. Last time I already sent to you a video discussion about the nervous system itself, and this time we're going to talk about some disease or illness associated with our nervous system. Okay, so we're going to start now. And the first time that we're going to talk here is all about your nociceptors, and most likely you are all familiar with this one already. So these are the sensory receptors that detect your signals from the damaged tissue or a threat of damage, and indirectly also respond to chemical release from the damaged tissue. So whenever an injury occurs, just like this one, it will send signals, and then it will go into your brain. It will be interpreted, and then it will be, you know, responded by our body. Okay, they actually play a pivotal role in how we feel and how we actually react to this kind of situation or the pain itself. And the main purpose of your nociceptor is to respond to damage to the body by transmitting signals to the spinal cord as well as to the brain. And as you can see here, we have like five classifications of your receptors. The first one is your chemoreceptor, from the word itself, chemo, which means some chemicals. Your mechano, it has something to do with mechanical. Your photoreceptor is from the light. Your thermo is from the temperature, and the nociceptor itself is from the pain. So if you're going to categorize whatever the stimuli that happened to you, you can just go here and look if it's chemo, mechano, photo, thermo, or nociceptors. Okay, these concepts here, they're very self-explanatory, so you can just read this part here. Now, how about this one? This is what we term as your referred pain. It is a type of pain that is actually perceived to be in one location other than where the pain stimulus is. Okay. Um, this kind of concept is very relevant, and specifically, you've studied this one in your health assessment, and you are assessing this one. Continue to, toughen your assessment skills in your duties, where you actually ask where is the location of the pain or how the pain radiates. This kind of questions you keep on asking to your clients in order for you to have, a formidable nursing care plan. Now let's just go here. For example, if the patient is in cardiac arrest, okay, they may experience referred pain or numbness in your left arm, upper middle part of your back, or it will extend up into your jaw, just like this one. Okay, so if the patient is in experience of having a heart attack, again, it will have, referred pain here on the left arm to your shoulder, middle part of your body or your back, and then it will go up into your jaw. So that is the referred classification in terms of pain for the client experiencing cardiac arrest. Okay, and then there are many more kind of um, referred pain. Now, some of the patients who are amputees, they can still experience pain even if their body part is no longer existing, and we refer that one as your phantom limb or phantom pain. Okay. Other things here, for example, your colon or your appendix. In many cases of the appendix pain, usually occur on the right side of the middle of your lower abdomen, while your kidneys They produce pain in a wide area that includes your abdomen, in your pelvis, in your lower back as well as your upper legs. Okay, so this is the concept about your referred pain. Now let's move on here in your mental status. So basically, this is what we always observe and what we always gather in terms of assessment to the patients who are confined in your intensive care unit. Okay, so we are checking the mental status of our client. So this is very crucial for you as a student nurse, that as early as now you have to, deepen, and you need to, widen your skills and knowledge about this one. The first one that we're going to talk is about the mental status that is alert in full consciousness. So this is just like us. We are in normal setup. We are in normal setting that we can, respond to any stimuli. We can converse to patient, to our clients, to our colleagues. We can do our ADL without any hesitations or alterations. That is your alert. Now, the next one is the awake. This one is fully oriented when aroused. An example, if you are doing your morning rounds and your patient is still sleeping, then you will just say, "Good morning, ma'am, sir. We will just be doing our rounds, or we will just be doing our morning care." With that alone, the patient will be awakened, and then he or she will be oriented with the things that is being done, or with the things that is about to be done to him or to her. The next one is lethargic. So it says here that drowsy but follows simple commands when stimulated. So sometimes here the patient actually has severe drowsiness, and he or she can be aroused by moderate stimuli, but then it drifts back to sleep. That is the feeling of being lethargic. Okay, how about the obtunded or somnolent? This one is arousable with stimulation, responds verbally with a word or two, and follows simple commands. Otherwise, it is drowsy. So this is like a state similar to being lethargic, in which the patient has a lessened interest in the environment, and it has a slow responses to stimulation. And the patient actually tends to sleep more often. Okay. However, they are still being stimulated by any kind of stimuli. Next one is your stuporous. This one is very hard to arouse, inconsistently may follow simple command, or speak single words or short phrase, limited spontaneous movement. Okay, so being in stupor means that only vigorous and repeated stimuli will arouse the patient, and when left undisturbed, the patient immediately lapses back to unresponsive state. So we often see this one with the clients who are actually about to be in coma, and then what you do is you stimulate them by, you know, um, making like rounds or circular motion um, in the chest area, or um, using a pen. You will arouse the feet, the plantar flexion if there are. You keep on repeating those things. However, the patient has very limited arousal to this kind of stimuli. You also have your semi-comatose, and of course your comatose. There are no responses anymore. There are no eye opening or motor behavior, especially there are no verbal already. So this is how are you going to actually assess the mental status of the client. Now let's move on here. So in mental status, assess the orientation and the memory. You can just ask the name of the client, what is the day today, what is the date, who's with the client, the address, the birthday, those things, those pertinent data that you really need to ask the client in order for you to check the mental status of the client. Okay, level of consciousness, your LOC. This is the single most sensitive indicator of changes in the neurologic status as well. We have your level 1, we have the conscious, coherent, and cognitive. In level 2, the patient is somewhat confused, drowsy, lethargic, somnolent, and obtunded. Level 3, it is stuporous. And level 4, we have your light coma, and we also have your deep coma. Now, in order for us to properly assess this one, we are actually using your GCS scale, in which it has been proven that is very effective. But this is also very crucial that you are very reliable somehow on assessing this one. So as early as now, you have to observe the nurses in the ICU, or you yourself or with your instructor. You have to ask them how to properly evaluate your client using your ECG. Now with this one, it's quite easy to understand or to memorize with the acronym EVM. And the E will actually stand for the eye-opening response, the V is for the verbal, and the M is for the motor response. So in the E, the eye-opening, you can just, merely see your patient opening and closing the eyes of the client. Okay, or if you're going to ask them to, "Ma'am, sir, can you open your eyes?" Or if you're going to stimulate them with, with external stimuli like the use of pen or the use of your hand to stimulate the patient in order for him or for her to open their eyes, okay, with the use of a little bit of pain. Now with this one, you can just easily how will I say this one? Wait, my alarm is on. You can just easily assess the client with this one, okay, for a while. Okay, so let's move back here. So the highest point here should be 4, and the lowest one is 1. Now let's go to letter V, which is the verbal, which means the patient is responding or oriented to time, person, as well as the place. The fourth grade with this one is being confused. The third one is the patient is using inappropriate words, or the patient is actually being gibberish. Number 2 is incomprehensible sound. The patient is just mumbling or moaning maybe. And the one is actually no response at all. So your M, your motor response, is it obeys command. "Ma'am, sir, can you just raise your hand?" Or "Can you lower your hand, raise your leg?" Those kind of commands, the patient will easily be doing those kind of things. So move to localize pain, flex to withdraw from pain, abnormal flexion and abnormal extension, and no response at all. So in your GCS, the highest is 15, and of course the lowest is 3. Okay, so I really wanted you to be oriented with this one and to do this this kind of assessment to your clients in ICU in order for you to toughen your skills. Okay, so we also have here your AVPU, alert, verbal pain, and unconscious. However, it's more it is more prominent, the one with the use of your GCS. Now let's go here. So what is happening here is that they're going to assess the eye of the patient using your PERLA. Your PERLA is pupils equal round, reactive to light, and accommodation. So what will happen here is first your doctor or the doctor will look at your pupil and note if they have an abnormal shape, or their shapes are not equal to one another, or the sizes are not equal to one another. Now, next is they do a swinging flashlight, just like what you can see here in the illustration. And then they move a small flashlight back and forth in front of your eyes while you look straight ahead, and they may do this a few times to see if your pupils react to the light. And lastly, your doctor will ask you to look at their index finger or the pen, and they move it close, far away, and from side to side as your pupils react. They'll check how well or poorly they focus on. Okay, most likely here, the abnormal assessment that they can find is what we term as your anisocoria. This one is which means that your pupil aren't equal in size, and about 20% of people live with this kind of condition. We have your pinpoint pupil as well. We also have your dilated pupils. I hope you already tried assessing this one. Basically, if a person has a pinpoint pupil, maybe they are because under medication, or they're under drugs. They also have damage in the pons area of the on the brainstem. Your dilated pupils, maybe the patient is in fear, in panic mode, in extreme anxiety, or maybe in seizure, okay, or maybe taking some prohibited drugs like cocaine, something like that. Now let's move on here to the next, the posturing. These are abnormal body postures, and they occur after a brain injury. So I think you've already met this term, your decorticate and your decerebrate. Okay, so what I just want you to remember here, in your decorticate, it will your arms are like C's, just like this one, and moves toward the cord. Your decerebrate, it's like letter E. Arms are like E, they will extend. Okay, now what is happening here in decorticate is that the damage of there's a damage in your cerebral hemisphere. There's going to be adduction and flexion of the arms, as well as on the hands. And if you're going to look at this one closely, the feet will be rotated internally with plantar flexion as manifestation. However, on your decerebrate, the damage is in the brain stems, okay, in the midbrain or in the pons. This is worst compared to your decorticate. There's also going to be adduction as well as extension of the arms. There's going to be pronation of the hands and extended legs and plantar flexion as well. Okay, how about this one? This kind of motor function test. We have your finger to nose test. I sent a video about this one. We also have your pronator drift, your oculocephalic reflex, and then your Romberg test. Okay, so with this one, they're checking your your alignment, your coordination, how you possibly have cervical spine injury or whatnot, your movement. Okay, please find the video on your Google Classroom. You also have here this one, the motor function test of your apraxia, agraphia, and then your ataxia. Your apraxia, actually here, this is the inability to perform motor activities like whistle, singing, as well as your smacking. Your agraphia here, this is the inability to write. And ataxia is uncoordinated movement characterized by wide base stance, just like this one. If you can see here in our illustration, it has a wide stance and swaying manner of walking. Well, this one, another assessment. We have your graphitia. This is tested by having the pain identified numbers traced on the palm of the hands while the eyes are actually closed. Okay, your stereognosis. This is the ability to perceive the form and nature of objects. And your agnosia is the ability to perceive sensory stimuli. You also have here your types of aphasia. I think I've sent a link about this one on how are you going to properly categorize the types of your aphasia. So we have your Broca's, your Wernicke's, your anomic, global, primary, progressive aphasia. With this one also, this one, it has been done many times in your health assessment. This is your how to check the reflexes of your client, the deep tendon reflex. You also have your plantar reflex and other types of assessment. In terms of the vital signs here, typically patient with neurovascular disease will be having respiration of Cheyne-Stokes, the respiration, crescendo, decrescendo respiration alternating with periods of your apnea. You also have hypoventilation, hyperventilation, shallow rapid respiration, and snoring respiration or stridor. In terms of your vital signs, temperature, we have your hypothalamus here, the regulator of our temperature. The hypothermia occurs with metabolic causes, pituitary damage, and spinal cord injury. While your CNS fevers may be very high and differentiate themselves from other causes of fever by their resistance to your antipyretic therapy. So most often than that, it is in cognition or in addition with your antibiotics. You also have your pulse and then your blood pressure here. These are just good to read. Let's go here with your assessment. So most likely we have here the Battles sign. As you can see, this is your battle sign. This is bruising over your mastoid area and suggests that it has your skull fracture. Well, this is what we term as your raccoon's eye. It looks like a raccoon, of course. So what is happening is there's going to be a periorbital edema and it has bruising. Okay, so it has your front area or your frontal area, fronto-basilar fracture to be exact. You also have your rhinorrhea. This one is the drainage of your CSF from the nose. And the last one is your otorrhea. This one is the drainage of your CSF from the ear. Okay. And how about these ones? These are your signs of meridial irritation or nuchal rigidity. We have your Koenig sign and your Brudzinski sign. So what is happening here is that there's going to be in Koenig sign, there's going to be pain in the neck when the thigh is flexed on the abdomen and the leg is extended at the knee. So what is happening here, it is an indication of your meningitis. Okay, there's going to be pain here if this one is being raised, being flexed to your abdomen. How about your Brudzinski's sign? Is that there's going to be involuntary flexion of the hips when the neck is flexed toward the chest. If you're going to raise this one, this body part of yours will be raised or elevated. Now here, how about your ICP? You've heard this one many times. Your increased intracranial pressure. This is the medical term that refers to the growing pressure inside a person's skull. So what is happening here, it varies actually depending on the person, the manifestation. If the patient is very young or if the patient is very old. So most likely infants with increased ICP have many different symptoms compared to children or adults. Okay, now what is happening here? And of course, it's because the newborns or the infants have or doesn't have a complete maturation of their body parts. Increased ICP in infants may also cause their fontanelles to bulge out. Okay, and the shape of their head will be affected as well. So, however, in adults, the manifestations here, you will just remember your Cushing's triad. Okay, which is here. This is the three primary signs that often indicate the increase in your intracranial pressure: increase in BP, decrease in pulse, and decrease in your respiration. Now, how are we going to um, assess the client in terms of doing some diagnostic procedure? So the first one here is what we have, your cerebral angiography, which uses a catheter, X-ray, and then a medium contrast to check the blood vessels of the brain, and if there are any abnormalities such as your aneurysm and the disease such as your atherosclerosis. Okay, so what you're going to um, remember here, because this is an invasive procedure, of course, you really need to have the consent from the client or from their relatives. Okay, we also have here your EEG. With this one, this is a recording of your electrical impulse generated by the brain cortex that are sent by your electrodes to the surface of your scalps. I think I haven't seen one of this one yet. Okay, so what you're going to do here is, of course, you need to make sure that the head of the client is free from dirt. Okay, and you really need to um, shave it if it's necessary. Of course, you need to ask the client first, or you really need to, shampoo it uh, and make it clean as possible so that there's gonna be interference in terms of the electrical impulses. Other thing is the lumbar puncture. You already know this one. The patient is in fetal position. This is also invasive. You really need to have the um, consent of the client. Okay. Complications most likely here, of course, if you have to check if there's gonna be leak of your CSF procedure, if there's gonna be headache, rigidity, fever, and difficulty voiding. Okay. In terms of this one, your CSF, the opening pressure should be 7 to 8, and the appearance must be clear and colorless. These are the laboratory interpretations. In terms of the therapy, we're going to have first is your hypermolar therapy. Hypermolar therapy is a treatment of intervention in the patient with severe head injury, maybe after a MVA or any kind of ischemic attack resulting in your cerebral edema and your intracranial hypertension. Okay, so we are using your hypertonic agents, your hypertonic saline, Um, Most likely here it is any solution of sodium chloride in water with a concentration of your sodium chloride higher than that found in our normal saline or your physiological saline. This is to induce your hypernatremia with the clients. Um, what is happening here is it's actually promoting the flow of the excess water. It's because a while ago we mentioned that clients with um, head injury can actually have cerebral edema and intracranial hypertension. So with this kind of solution, it will promote the flow of the excess of the water from your cerebral tissue to the blood with the use of your osmosis, and then decreasing the edema in our brain. You also have here your mannitol administration. So your mannitol here, it is your hypertonic crystalloid solution that decreases as well cerebral edema. Okay. We have here your respiratory support, your normocapnia. This term is the state of normal arterial carbon dioxide that is usually about 40 in our body. Their pharmacological therapies, the use of analgesics, sedative, paralytics. We also have the use of fentanyl and morphine. These are opioids, and also your naloxone. Okay, we also have if the patient is, you know, it's um, keep on moving. Of course, it's because they are not oriented. Maybe they need to be sedated, and we can use your benzodiazepine, your midazolam, diazepam, and other kinds of sedative. We also have your anesthetics. And what you're going to do here is to, you know, check the blood pressure of the client. We also have some seizure prophylaxis here. Maybe the client will be in seizure state. So let's move on here. So these are the type of, you know, the pain that we actually feel in our head. It can be a migraine, it can be a tension headache, your sinus headache, or your cluster headache. Okay, the location for this one is, example in the migraine is one or both sides of the head. In the tension headache is one or both side of the head or the neck. While the sinus, of course, is in the face, forehead, and between your eyes. The cluster headache is one side extending from behind your eye. So, the management for this man, of course, is you really need to have some rest, quiet environment, stress therapy, and relaxation techniques, and some medication, some diet as well. Small frequent diet with the avoidance of chocolate, coffee, nuts, uh, and also coffee, dairy products that will stimulate your digestive or your respiration or any other kind of things. It's because you really need to have rest if you feel pain with this one. Some medication here, we can actually have your beta adrenergic blockers or your type of pain reliever. Now let's move on. Here we have your cerebrovascular disease or the stroke. What is happening here is there's going to be a thrombosis or embolus or hemorrhage of the brain that can actually damage the area in our brain. It occurs when there is disruption in the blood flow on the region of the brain, maybe because of some thrombus or some embolus. Okay. And the next one here is we have your stroke. We have ischemic, and we also have your hemorrhagic. It's because of this one, some plaques or atherosclerosis or blockage. There's going to be a regurgitation of the blood flow, or hemorrhagic stroke. Our blood vessels are very weak. There's going to be sipping, or the blood will be, you know, will move out from the blood vessel. So how are you going to properly check the client if they are having stroke? You need to spot a stroke or be fast. Okay, check the balance of the client, the eye of the client, the face of the client. If there is like a drooping, if drooping on the other side, the arms, you ask them, to spread their arms or what, if they cannot do that one. Speech, if there is like slurred speech, difficulty of speaking, and time is time to call the ambulance immediately. Okay. Now, most often than that, you already know this one. This is your thrombus, and then this one is your embolus, the one that is being, discharged, and it will go to other parts of our body. Next one is we have your transient ischemic attack, or your TIA. So from the word itself, transient, it will go from one place to another, or it will not stay that long. So this is neurological deficit lasting less than 24 hours that is attributed to focal or retinal ischemia. Okay. So our initial treatment with this one, of course, oxygen. We need to also get the ABG analysis of our client. We need to check the pulse oximeter. Again, it should be 95 to 100. Lower than that, you really need to have your oxygen therapy, or you have to call immediately the doctor, or you need to check if the sugar level is actually very low. The next one is the glucose. You need to check, it's maybe the patient is having hypoglycemia. Reperfusion, of course, if there's like IVTPA, or that is your intravenous tissue type plus plasminogen activator, or thrombolytic medication. Anticoagulants as well, we really need to have that one for our client. Okay, the control of your hypertension as well as the increase of your ICP, we really need to check those things. So they are very crucial. And of course, if there's going to be decrease in ICP, we really need to how do you call this one, to manage or to assess and check the blood pressure religiously. Okay, the blood pressure must be regulated if the patient must have or experiencing increased ICP. We also have some surgical management, as well as carotid in the endarterectomy to prevent stroke, hemicraniectomy, and extracranial or intracranial bypass surgery. Other things here, emotional and behavioral modification. You already know these things. Communication. I think this fascia or global dysphagia, I think I sent this one with another link in your GCR. Let's move on here. How are you going to assess if the client is in the right or in the left brain injury? So if it's going to be in right brain injury, the manifestation or the affected side is on the left part of the brain. If it's the left brain injury, it's going to be on the opposite. It's going to be in the right brain injury. And you've already know these things. What will be the manifestations? Paralysis, of course, has something to do with the verbal. The patient will be unable to speak properly as well. How about this one? Seizure. This is an episode of abnormal and excessive discharge of your cerebral neurons, and it can result in the altered sensory, motor, or behavioral activities. Can be associated with changes in your LOC as well. We have here your epilepsy. This is a condition in which seizures are spontaneous and recurrent. What I want you to remember here, if we say seizure, this is single occurrence of a jerky movement and other features of a fit. While your epilepsy is defined as two or more than two unprovoked seizures occurring in an individual. Okay, they actually have types of seizures that later on we're going to tackle. We have your status epilepticus here. This one is very rare. Most people with epilepsy will never have this one, and this condition is more common in young children and in elderly. Okay, so this will last for, I think it's 30 minutes. We have here your classification. So here, this is what we have: your um, generalized epilepsy or seizure. Here we have your tonic-clonic, or this is what we term as your grand mal. The LOC, stiffening or focus. What is happening here in generalized tonic-clonic seizure? Diffuse type of generalization that is characterized by stiffening. This one is tonic. This is the body is being stiff. Okay, and clonic here, the body is actually moving. Okay, this is the most common for the epilepsy, and it is thought to be caused by the abnormal brain electrical activity. Okay, so if we say clonic again, what you're going to hear is there's going to be a bilateral jerking, while your tonic here on this side, there's going to be a increased tone and force expiration. We also have here, this one is your myoclonic. Your myoclonic is sudden, and there's gonna be a brief body jerk. Okay, I think this one is your myoclonic, this part here. Okay, the seizure involves twitching, which can be just one muscle or several muscles at the same time, and then these twitches are usually quick. They last for just seconds or two, a second or two rather, but they can be maybe within short period of time. Your atonic, which is this one, yeah, this is the atonic, this is the opposite of your tonic. During an atonic seizure, there will be loss of muscle tone, which causes the young person to suddenly flop towards and fall, just like what happened here to this guy. It is very sudden. The muscle will be in loss in terms of control, and then it will flop forward and then they will fall. And we also have your absence seizure, used to be referred to as petit mal. They often begin in childhood and do not usually continue in adulthood. They may occur many times a day to provoke a brief trance-like state of unconsciousness. You also have here your focal or partial, involves one hemisphere. Simple partial pressure here, no change in your LOC or your Jacksonian jerky movement. Okay, we have here what we term as your Jacksonian. So as you can see here, they're common among patients with organic brain lesions like frontal lobe tumor. This is also a tonic-clonic movement groups of muscle. Example are your hands, your foot, your face, then proceed to grand mal seizure. If a patient will also be having a very high grade fever, they can actually also result to seizure, and that is what we term as your febrile seizure. Also have your psychomotor seizure. Um, this is like a psychiatric component, and aura is present. The usual management for this one is, of course, we really need to stay with the client. We need to protect the client from injury. We need to have a padded side rails. We should not be restraining the client. We should not be inserting tongue blade to the client. Ease the patient on floor and with pillow head, so that their head um, will be protected, and promote patient or patent airway. With that, the patient will be diagnosed with ECG, MRI, CT scan, and epilepsy monitoring unit. And these are the normal or the typical drug therapy for the patients with seizure. You can just read these things in the PowerPoint sent to you guys. Last one, we have your Guillain-Barré syndrome. Your Guillain-Barré syndrome, this is also known as your acute inflammatory demyelinating polyneuropathy. That's so twist. It is a rapidly evolving illness commonly present in your symmetrical weakness, sensory loss, and as well as your flexions or affliction. Manifestation here, there's going to be ascending paralysis that develops quickly, and you can just see this illustration here. This one. So this is like this one is your MG. That is your myasthenia gravis. This one is more of weakness, more of neuropathy. In comparison with this one, this is your MG, your myasthenia gravis. This is autoimmune disorder. So usually the patient is having, a drooping face, just like this one. So, and this one is manifestation for the kids. Some diagnosis here: ECG, clinical management manifestation. You can just read this one. So your cholinergic toxidrome here. This is myasthenia versus your cholinergic. Your myasthenia crisis is respiratory failure along with sudden exacerbation of weakness in other muscle group. Your cholinergic here are muscular or nicotic side, increase in perspiration, abdominal cramping, and diarrhea. Patients' education and discharge plan are very crucial with the clients with this kind of disease. Okay, and that will be it for your nervous system in terms of critical care. So good luck on your exams, and I'll see you again next time. Thank you.